So our next speaker is Dr. Steve Felder, and he's going to talk about what's new in topical anti-inflammatory agents in the management of atopic and vernal conjunctivitis.
Thanks, Sophie. I'd like to thank the organizers for the invitation to speak. These are my disclosures. The immunopathology of allergic conditions varies between seasonal allergic conjunctivitis and atopic and vernal conjunctivitis. Seasonal allergy involves innate inflammatory cells and mediators with circulating and locally produced IgE immunoglobulin that binds to conjunctival mast cells in the sensitization stage, and subsequent allergen binding to the mast cell IgE, stimulating mast cell degranulation. And there's an immediate reaction with itching and edema due to histamine release, and a late phase reaction with histamine and other inflammatory mediators. Atopic and vernal keratoconjunctivitis involve innate plus adaptive immunity, including cytokines produced by Th1, such as interferon gamma, and Th2, such as IL-4 and IL-13 cells. Atopic dermatitis is a significant cause of ocular morbidity, with eye or eyelid involvement occurring in 20 to 43% of patients. And many of those patients develop corneal epithelial disease, up to 70%, with corneal neovascularization in 60%. 67% of patients with atopic dermatitis had increased Staphylococcal aureus colonization of the conjunctiva and eyelid margins, and stimulation of innate signaling pathways like the toll-like receptor pathway have been implicated. As you can see in this figure, in atopic keratoconjunctivitis, there can be goblet cell hyperplasia, although actually in some patients they can develop a reduced number of goblet cells that can resemble keratoconjunctivitis sicca, and then there is involvement of both Th1 and Th2 lymphocytes, eosinophils, and neutrophils. Almost everyone in the room recognizes that there's a markedly increased risk for keratoconus in patients with chronic atopic disease, possibly from eyelid rubbing or from the inflammatory mediators in the conjunctiva and tear film. And those patients also tend to develop corneal vascularization, as can be seen in this patient on the right, that develops severe vascularization and lipid keratopathy and radial keratotomy incisions. And then from the superior tarsal thickening and inflammation, there places much more stress on the corneal epithelium and the limbal stem cells. And as you can see, similar to the talk given this morning by Dr. Cruza, there's evidence of limbal stem cell deficiency with increased fluorescein uptake in this patient. Vernal keratoconjunctivitis affects mostly young males living in subtropical and tropical climates, and they develop ropey discharge in these giant papillae, which can often contribute to mechanical trauma to the cornea and produce these shield-like ulcers, either single or multiple ulcers, and very frequently there's limbal inflammation and can be Horner-Trantis dots. In vernal keratoconjunctivitis, it's primarily associated with Th2 cells with increased production of those mediators such as IL-4 and IL-13, as well as mast cell degranulation, eosinophils, and neutrophils. To treat seasonal allergic conjunctivitis in the mild and episodic conditions, we can primarily rely on the antihistamine mast cell stabilizing agents, of which there are a number of great ones on the market. And if it's moderate or acute and chronic, then you could consider low-dose corticosteroids or calcineurin inhibitors. And for AKC and vernal, therapies based on the severity of the conjunctival and corneal disease, and includes both antihistamines, calcineurin inhibitors, and then low-potency or pulse, higher potency steroids. The antihistamine mast cell stabilizers can act at several sites in the conjunctiva. They can inhibit histamine release from mast cells. They can, as well as other inflammatory mediators such as cytokines or chemokines. They can block binding to the H1 or H2 histamine receptors on nerves or blood vessels, inhibit eosinophil activation and cytokine release, and inhibit mediator release from basophils. Topical antihistamines are a commonly used option for the non-severe acute and chronic allergic conjunctivitis, and now there's several good over-the-counter options as well as prescription options. And the newer formulations, such as olopatadine or epinastine, have both mast cell stabilizing, and some of them have both H1 and H2 receptor antagonists and anti-inflammatory properties. And then, as I mentioned, you can consider pulsed or chronic low-potency corticosteroids for the most severe cases. When it's more severe, I tend to prefer a higher potency steroid such as dexamethasone 0.1% and try to use preservative-free formulations or diflupronate or prednisolone, and then taper to soft, lower concentration steroids. And then in very severe cases where there's a lot of superior tarsal inflammation, consider supratarsal dexamethasone or triamcinolone injections, which can really decrease the inflammation in that area. Both cyclosporin and tacrolimus, which are calcineurin inhibitors, have been reported to improve signs and symptoms of AKC in these articles. I tend to prefer tacrolimus in the 0.3% concentration. And those calcineurin inhibitors prevent calcineurin phosphatase activity on NFAT and limit T cell activation and production of both Th1 and Th2 cytokines. Effects can be quite dramatic, as you can see in the top figure. Before tacrolimus and 1 month after tacrolimus, there's a marked reduction in the limbal inflammation. There's also a number of therapies in the pipeline, including the reactive aldehyde species inhibitor, which has shown decreases in itching symptoms in a cat model. And then more recently, trials have started for the dexamethasone punctal insert. And there are also completed or inactive trials, although the top treatment, the humanized monoclonal anti-singlet 8 antibody, is actually, their results are being reported at the Academy meeting here by Dr. Joe Tauber. There are other management challenges, including chronic epitheliopathy, non-healing epithelial defects, neovascularization, and limbal stem cell deficiency. Neovascularization can be treated with photocoagulation, bevacizumab, and triamcinolone, and non-healing epithelial defects with scleral contact lenses such as PROS and PRGF. Finally, I'd like to leave you with a new clinical entity. This is a 28-year-old that had atopic dermatitis for 13 years and developed new onset redness and foreign body sensation in both eyes 3 months after starting Dupilumab. There was no history of prior eye problems. So there was a query whether this was AKC or was it therapy related, and it turned out to be Dupilumab conjunctivitis, which occurs in up to 23% of patients receiving Dupilumab, which is an anti-IL-13 blocker. This is treated with both topical steroids and tacrolimus. It causes, or in some cases, severe goblet cell loss. So in summary, we have increased knowledge of the pathogenesis of these conditions that involve both innate and adaptive immune mediators. Consider combined therapy, and now that hopefully you'll recognize the Dupilumab-associated conjunctivitis. Thank you very much.
Thank you so much. It's a great talk.